Top Bed Talk.
Nick Majerison here. This piece is taken from EBPOM London and is presented by Monty Mythen and Kay Mitchell, Senior Research Manager for Critical Care Research at the NIHR Biomedical Research Centre, University Hospital, Southampton, in the UK, with their guests David Selwyn, Deputy Medical Director, Nottingham University Hospital's NHS Trust and Director of the Centre for Perioperative Care, alongside Sol Aronson, tenured Professor, Duke University, and Jeff Vender, Emeritus, Harris Family Foundation Chairman of the Department of Anesthesiology at NorthShore University Health System, and Clinical Professor at the University of Chicago, Pritzker School of Medicine in Chicago, Illinois. This piece has been available to EBPOM London attendees since it was recorded in the earlier part of the year. For exclusive access to other similar pieces, now and in the future, please visit ebpom.org. That's ebpom.org.
Sol, I'm going to come to you for a second. You gave me 5 tiers. Do you just want to reiterate those 5 tiers as to why you think the business case for more detailed perioperative care makes sense?
Sure. In my own vernacular, I kind of looked at the evolution of perioperative care, particularly in the setting of preoperative assessment over the years as we've evolved. And I think we have now been able to characterize what I'll call the first tier, the first economic, if you will, tier of having a patient come to a pre-anesthesia, pre-surgical testing center, because we've shown over and over again that when we do that routinely, reduce significantly first-time starts, case delays, postponements and cancellations, and that is a important variable in the throughput and the efficiencies and productivities of just day-to-day living. And indeed, that has been the source of justification for a lot of us to bring patients into these pre-anesthesia testing clinics a priori. It's interesting, back in the 70s and 80s when we were residents, Monty and Jeff, it was routine for patients to be brought into the hospital the night before surgery, maybe even a day or two before surgery, and we would just make our rounds and we'd see the patients in-house and we'd do the checkbox. And then in the 90s, as same-day admissions became more and more the standard to free up bed space, the pre-anesthesia testing clinic, if you will, emerged. And so it was almost an unintended response to a intentional consequence of efficiency. And so we learned right away that when we brought people in ahead of time, instead of seeing them the day of, that we were able to make life more efficient. First tier economics. Second tier economics is what I would call, we also discovered that by seeing patients earlier than the day that they came into the clinic, we reduced waste. We were more efficient in our laboratory testing, our diagnostic ordering, and the reduction in just redundancy itself was a cost driver. What I'll call the third tier of economics is something that's near and dear to us in the States because we're still principally in a fee-for-service model, which is contribution margin, that you can get paid for doing work. And it's a piecemeal sort of mentality. But as you see patients and you evaluate their readiness based on their intake exams, their E&M codes, if you will, and maybe even learning that you need to do something downstream to optimize their anemia or their nutrition, those are all coded events that we can record and get paid for. I'll call that third tier contribution margin. All that's interesting and real, but the real bingo, if you will, is what I'll now call the fourth tier. And that's cost avoidance. And what we're now confronting in this country is the fact that in a more and more value-based care model, as we inch closer to capitation, it's the mitigation of the downstream adverse event that is going to be most cost consuming in terms of the expenditure. And so if we can do something upstream to optimize the patient, to get them ready for surgery, if you need surgery, you need surgery, but you shouldn't have surgery until you're ready for surgery. And if we could do things to mitigate those modifiable conditions so that we can diminish the downstream adverse events that would more likely than not be a consequence of not taking care of that, then we contribute significantly to what I call cost avoidance. And that's, if you will, where we're in the slam dunk phase of the economics. To even take it a step further, I think there is a population health component of health care value proposition. I don't think we're as mature in that realm yet, but if I were just to finish the loop, that would be the fifth term.
Jeff, go for it. Why are you less? I think I'm putting words in your mouth here. I know you think these are all worthy endeavours, but from the point of view of the business case, is it such a slam dunk that Sol's suggesting?
No, it's not a slam dunk, and I'd be naive to say that I do also agree, whether it's prehabilitation, ERAS, whatever we're talking about, there are clear benefits to all of this. Our ability to measure them and then not have attribution bias to what produces them is the problem. I'm a big believer in Pareto's principle, that the 80-20 rule, 20% of what we do gives us 80% of our result. And my concern when I read the articles that have come out about prehabilitation, read the articles about ERAS, and then look at the history in hindsight, that we are doing lots of things that are unnecessary to get the results we're getting because we don't know how to measure them. We've all lived in our eras of anesthesia and critical care, whether it was Xigris, poison with beta blockers, ventilation, steroids. What looked like fabulous results never turn out. And then when you read the individual articles, and I'll stop here, my biggest problem with them all is how to measure our results and define our results. When my wife had a baby with an epidural 42 years ago, she was in the hospital for 3.5 days for just a routine delivery. Today, that woman could go home the same day or for sure the next morning, and not because she got a different epidural. She was told she's going home. So is that ERAS or is that patient expectation? We can come back when we talk about frailty or other things in this conversation, or some of the data that has been permeated to warrant everything Sal said. But the last point you brought up, Monty, was value versus volume. You know, in a lot of ways, how do you pay people? In the United States, my problem with the value proposition is how do you measure it? Who defines it? Volume is easy to define. Units of work are easy to define. In this country, the only reason value is coming into the equation is a method to reduce cost and reduce reimbursement over something they have trouble measuring. Now, that's somewhat antithetical and cynical, but it's also somewhat true. I'll stop there, Monty.
So, Jeff, just to come back at you directly myself before the others come in, I can see where you're coming from as a scientist, as a clinician. But if you put your business hat on, if you're getting a return on the investment, do you really care that much what resulted in the outcome, providing the outcomes are better?
No, I mean, if you have a clear return on investment from a business perspective, you should be doing it.
Okay.
I find the numbers, what I find when I read the articles is I have a difficult time attributing the result and the numbers to anything. I mean, when we get to it, I'll talk about the Michigan study on surgical project and health organization project that they did on prehabilitation, published a couple of years ago. And they had a financial return. And it was very significant. But if you read it and look at everything, you'd have a hard time understanding how that return was there and those numbers were generated. So the first thing is you got to believe the numbers. You got to believe the numbers. You know, okay. So if there is a true return, then I'm in for it.
So Dave Selwyn, who is joining us today as the director of the Centre for Perioperative Care, an organisation in the United Kingdom relatively recently formed. So I'm guessing because of the title that there's people that think that this is a slam dunk and that you're being asked to be part of the leadership team to deliver it within our National Health Service.
Yes, Centre for Perioperative Care, it's been established just over a year or so. The laudable aims to deliver the whole of the perioperative pathway and to bring together patients, the public, and various stakeholders, including the medical royal colleges, to try and deliver this in the UK. It's a bit different to the American model that you've been hearing about, of course, because we don't have the fee per service in the NHS. And so in terms of business cases, our ability to make those pay depends on our ability to show that they actually have some benefit. And I guess picking up on the comments that's already been made, certainly reducing your major complications would be a key component of that, reducing your length of stay and anything that you can show that's been delivered. And of course, giving patient satisfaction in some phrase, however you want to capture that, would be ways that you could act.
So I just challenge you a little bit there, Dave, because although we always talk about the NHS in those terms, and you've been involved in managing within the NHS, as I think as a medical director type of role. So you've looked at the books, you understand the money. We do have an internal market. So we do effectively, to a certain extent, compete for business. And we do have a tariff rate that's associated with those procedures. And we can make a margin if our outcomes are better. And that means that the parking's easier and the scrubs are better and the coffee's better. So how's it really that different? Aren't the drivers ultimately quality and therefore value? And the better you do it, the bigger the margin. Have I missed something there?
So I think all of us would completely agree that quality is the key aim, and that if you get the quality and the safety aspects right, and the happy patient with the correct results, then the money is highly likely to follow that. In terms of balancing the books, that's really interesting. So the problem that we have across the NHS is that it's not as though every single service makes a profit, and you have to balance those that make the profit with those that make the loss, and that's how the most of the NHS trusts work. So, for example, if you take complex eye work, so ophthalmic surgery, and you look at cataracts, that makes a fairly healthy profit, and not surprisingly, that's partly why it's creamed off to some degree within the independent providers. But if you take more complex ophthalmic surgery in terms of perhaps the actual retinal surgery, then that tends to, in terms of the tariff, to the costs that we spend are greater than the tariff that we get, so that makes a loss. And so you have to take the whole service in terms of the profit-making cataracts with the loss leaders to make it. Within the world of our finances are all a bit up in the air, and most of us have moved from the internal market and have moved from tariffs. That most of us are on block contracts now, and this is the way going forward that we're probably going to have to deal with the NHS.
But I'll jump ahead to go into the detail of it now. But when it comes to the block contract, and then more about that is the sort of capitation according to a population. Do you buy this Sol's fifth tier of the population health benefits if we get this thing right? Or do you think that's highly speculative at the moment?
For me, the real money in what we can do in perioperative care is to influence the health of the population. And the problem with this is it's not very exciting, it's not very sexy, it's not got a dial that moves massively, but actually in terms of the value for the population and what we can do for healthcare, that's the most important thing. So if we can get into those population health management discussions and actually influence what we can do, the prevention agenda, stopping people smoking. You heard Scarlett talking about 18% reduction in complications if you stop people smoking a few weeks before you have your operation. The same for controlling your diabetes, trying to get a bit better exercise, all of those aspects. If we can get into that, then that's really where the money is. So I would support all of that.
Kay, in your lecture, you describe your early journey with cardiopulmonary exercise testing. And I got the impression that one of the reasons it was successful early on within the National Health Service is that you could eliminate the cost of some unhelpful or unnecessary tests. And the second thing was you could cut down unnecessary referrals to other ologists, so to pulmonologists or cardiologists, because you did a one-stop shop test and you decreased extra testing and referrals. Now, in our system, that works because more work is just more work. It's not more money, is it? So is that correct in the early stages that you were able to... Everyone was smiling. Your cardiological colleagues were smiling. They weren't hating you because you were decreasing referrals.
No, absolutely. It allowed us to give... And also, I think it's important for the patient because you can give the patient a better understanding of what their risk is and what's likely to happen to them. And it allows you to decide whether you need to electively book an intensive care bed, so you can control that patient's pathway much better, which reduces the risks and the chance of having complications post-operatively, but also you make that patient's journey much better, and then you get better patient-reported outcomes as well.
So by coming to, let's call it your clinic for argument's sake, for the simplicity of discussion, by coming to you, popping them on the bicycle, doing a cardiopulmonary exercise test, a one-stop shop, you decreased the number of stress echoes and decreased the number of lung function tests and decreased the number of cardiological referrals.
Yeah.
Is that a fair comment?
I would say that's true, yeah.
Now, Sol, I always got the impression that at Duke, where I used to work, that would make you unpopular. Because if I'm not referring to my cardiological colleagues for advice on hypotension and hypoxia, I'd be cutting off some of their income streams. Is that not true?
To a degree. I think what you have to appreciate before that question is answered easily is that at Duke or any, site in the States, we're right now in a transitionary period. I like to use the metaphor, we're walking on that tightrope between volume to value, if you will, and some of us are having to walk on a very long tightrope. Some of us are having to walk on a very narrow tightrope, but it's a tightrope, and we all know that the destination at the end of that journey is an inevitability. We're going to value-based care, but we're going about it slowly, and so we're having to balance the fee-for-service realities that you speak to versus our collective, if you will, communal efforts to manage health care as a society with the concept of total cost of care being preeminent in our goal, and to enhance value by addressing quality metrics against total cost of care. It's a pithy question that deserves, I guess, a pithy answer to say, yes, indeed, nobody wants to take away the food off of somebody's plate, but I think it's more complex than that, Monty. And so the answer is it depends on the system, it depends on the alignment within the practice and the totality of the commitment for total cost of care mitigation. To Jeff's, can I jump in and just speak a little bit to some of the comments that Jeff had made that I thought were right on. I think his points about measurement is what underscores our need to sort of hold ourselves accountable. That said, I think what we choose to measure and how we choose to measure it is really critical. And if we continue to think of ourselves, Dan and Jeff, in the isolated, if you will, corridors of just the OR or anesthesia, then we are vulnerable to cost shifting rather than true cost mitigation in a total cost of care model. I think what we can do in perioperative medicine is really bend the total cost of care curve. What we have shown and data supports is if somebody is anemic, they are more likely to have adverse health economic outcomes, defined as increased length of stay or increased likelihood of readmission at 30 days. But even objectively, we've actually been able to show that for every unit increase in hemoglobin, there's a half a day diminution in length of stay. So now when you're confronted with, do I put that case on the schedule because we have an open block in the room and we want to be efficient, or do I postpone that case? We can use science now to apply to that economic, if you will, perspective of whether or not it makes best sense to postpone or go forward. And I think that's equally true when you look at nutrition health or smoking health or diabetes health and on and on. So I think the science of perioperative medicine from a value-based proposition is very nascent, but it's very real.
So, Jeff, I'll bring you in there. Let's take the anemia example, or any of one of the examples that Sol chose. Well, actually, I've got two questions. The first one is, do you think that this argument that the walking the tightrope from volume to value is going to complete itself in the USA soon? Some people don't seem to be as certain as Sol is about this.
I think there's no question. It's moving in that direction. And the COVID crisis we've just lived through, which has impacted numerous hospitals dramatically, will accelerate that, because as the dollars shrink, you've got to do something.
Yeah.
And the easiest thing is to pay everybody less and make it their problem. It's not necessarily the right thing. Going back to, so I think it's going to be a transition. We have failed at every other attempt in the past, but it's going to become a necessity. But I don't think the dollars are going to be there, and they're going to throw it back at us because they don't know how to solve the problem. Having said that, let's talk about what Sal just said a second ago. I think there's no question. When you look at any underlying, and I don't want to call it a comorbidity, because smoking is not necessarily a comorbidity. It's what smoking does to you is a comorbidity. Anemia, the question isn't, are those things good? Anytime you can take care of a healthy patient, anytime you can take care of a patient that reduces their morbidity, that's great. But how do you do it? What's your time frame? So do we know that patients with a hemoglobin of 11 do any better than 10? I don't think so. We know that low hemoglobins are bad, but we also know transfusion is bad. So if you've got time for iron or other mechanisms to treat the anemia, i.e. if it's bleeding, you got to do something. There's lots of decisions that go beyond just the one parameter we're measuring. Smoking. You change your O2 dissociation curve in a couple of days, but we don't know if it's 4 or 8 weeks yet where you will dramatically impact the outcome. And then if the smoking is long enough and bad enough, the underlying lung disease isn't going to change at all. So all of these things that we would call modifiable risk factors are real. Weight loss is real. How much time do you have to lose 50 pounds before a total knee because you're 360 pounds to improve your outcome? How long do you have to lose 50 pounds if you've got cancer? So it's not as simple as saying we want to modify something and we know it's bad. We know all these comorbidities are bad. It's what can we do in a reasonable period of time? And the last point I'm going to make before you take it, Monty, is, when we talk about costs, we're always chasing. To me, it's like the dogs at a dog track chasing the rabbit around the track. You never catch the rabbit. We are hung up on a lot of different things, but the one thing we haven't done in the U.S. is understood palliative and hospice care. And if you look at our ICUs and if you look at a lot of the cases we do with the new cardiologic techniques or whatever, you've got to question our decision-making, not on an ethical or moral basis, but on a value basis. And we will save a lot more money if we give our care where it makes the greatest difference. And that means not everybody's going to get it the same. And that's a hard factor for us to get our hands around as individuals. We just can't do it for everybody.
So I'm sitting here thinking everyone's starting to agree with each other. You're coming at it from slightly different angles, Jeff, but I think you were suggesting to me that it may not be the fact that you fix things immediately adjacent to surgery, but ultimately it's better to try and fix those things if you can. Because if you're the insurer or the payer, which is ultimately always us, if you see what I mean, it's good if we get on and fix those things. And should we take the Sol's philosophy and say you shouldn't go for surgery till everything that you can fix is fixed?
To be clear, I'm not saying that. I don't want to be characterized by that. What I'm saying is that I think there's an elegance to the question that we heretofore haven't asked in an elegant way. So to just simply say that sick people do less well than healthy people is true, and to say that well-managed sick people do better than poorly managed sick people is also true. And nobody discounts that or dismisses that. But where the sophistication of the question lies is where I think we're at in the challenges, which is everybody's well-intended, everybody is smart, everybody is good. I don't think we should walk into any situation without those assumptions. But whether or not you should post that patient who needs surgery, I'm not talking about urgency and emergently, those are dealt with emergently and urgently, but whether or not you should post that patient who needs surgery for surgery and not manage what are those modifiable conditions is a very difficult question, because you have to balance the impairment for surgery. They need surgery, so they should have surgery, versus whether or not they're truly ready for surgery and we could do something laudable and improve their outcome of recovering from the perturbation of surgery by managing their if you will, modifiable conditions preemptively. And that's a science that we're just beginning to dip our toe into the water for. What we've learned in some of our experiences now at Duke, because we've had this wonderful system that has enabled us to study that, is that the answer is, Jeff, for example, there's a 7.5% decrease in length of stay for every unit increase in hemoglobin. So there is a difference between a hemoglobin in 10 and 11, to your question. Now, it may be invisible to the practical aspects of what constitutes recovery, but those are data points that we should integrate into our decision as whether or not we should postpone this knee replacement for 2 weeks so we can give them some iron therapy, or whether or not we should give them surgery next day because their knee hurts really, really bad. And I think we have to sort of now factor into those variables. I can tell you we have similar data for nutrition health, for diabetic health, for like chronic pain syndrome help, et cetera, et cetera. So all those conditions now need to be weighted. It's a complex medical decision. And I think as we have more opportunity to weigh all of those, if you will, components, we can make informed decisions and try to bend that curve.
But Jeff, come back on that, please. Is that true related or?
No, I think Sal might have data to show exactly what he has shown. But there's an equivalent amount of data out there that says if you transfuse somebody to take them from 10 to 11, their outcomes will be no better. And in some situations, the speculation is they might actually do worse by getting the transfusion.
That's the transfusion.
Different disease. Yeah. It's a different disease.
Hemoglobin level. You're relating it to hemoglobin levels versus what caused the level, how you manage it, and underlying processes. So I agree with you. I'd rather have a hemoglobin of 13 under the right circumstances than a hemoglobin of 9. But why does somebody have a 7? Why does somebody have an 8? Did they have prior chemotherapy? What are the other issues that lead to these comorbidities that it's not as clear as saying, I'm going to hold up doing something because you're not 13, you're 12. And you might be 7.5% better. There's got to be a diminishing benefit that the data doesn't show.
So of course that you want to understand etiology, and it goes without saying that perhaps we should say that most of these patients that we're now speaking to are those patients who have been, after a diagnostic algorithm, declared themselves to be iron deficient, which is the most common, if you will, diagnostic etiology of pre-surgical anemia. But you're right. You want to screen out those what-if scenarios, but I'm not talking about the what-if scenarios.
So Kay, where you work in Southampton, the National Health Service, the things that Sol's been referring to, I think we are convinced that they are worth doing and they're value for money.
Absolutely. And I think something that's come out within the NHS recently is the NHS long-term plan. And that's all about trying to improve people's long-term fitness and health. And it's about looking at comorbidities and smoking and cessation and alcohol dependence and trying to make small changes with all of those things across the board, particularly in the community as well as in acute care, to actually improve outcomes and reduce cost. And that will also make improvements in patients' experience and patients' enjoyment of life.
Dave, a couple more comments from you and then we're going to go to Slido.
Yeah, it was so interesting. So I've enjoyed the American take on this. I guess that what we're talking about is as clinicians, we love to get focused on, oh, look, here's a problem, let's fix it. Let's give a unit of blood, or let's give half a unit of blood, or let's get that number to a different level, because we can conceptualize that. Actually, I think the bit we haven't touched on is that societal approach. There are vast swathes of patients out there who need our help to lose weight, to give up smoking, to get fitter for their surgery. And actually, that's where the real money is. If we can get into those conversations, then we have the opportunity to really influence the outcomes of our patients.
Good, excellent. I'm going to move to Slido. So the first two questions are up here with a total of about 36 votes related to preparing patients in the time of COVID-19 for surgery. Now, I'm going to come to you, Jeff, and then you, Sol, quickly to reflect on getting elective surgery rebooted in your environments for all the good reasons we can see why we need to get on with it, but the challenge of doing that too quickly in the context of COVID-19. What have you done?
We have rebooted to the point of 75%, let's say, of our pre-COVID volume. Every patient we do now is COVID tested 72 hours ahead, self-quarantines prior to the procedure in theory. They're supposed to self-quarantine. They come in. The key elements have been our staff and how prepared they are with protective personal equipment, so the PPE stuff, how we manage these patients from the minute they come in the front door, how we manage our own employees. And we have been successful as far as we can tell without issues. The hard ones are the inpatients or the emergent cases where you're not going to be able to test them, but we were doing those before. Where the throughput like in GI, might be so high, you have too much contact between people. So it's not one size fits all, but in the main operating environment, we have felt pretty good about our social distancing, our PPE, screening the patients as best you can at every level of inquiry, and going from there. So with that structure, it's been pretty successful. And I think there are people even come back more than us. A lot of it, the last point, it also depends on your ICU capacity, because if you look in parts of the U.S., ICUs are filling up again, where we've gone from 180 COVID patients and 50 critical care patients with COVID. We're now down to 10 and 30. So that's also helped from capacity.
And Jeff, in your part of the country, you get the impression it's holding down? I know there have been some suggestions it's been holding up in other places, but
I think most of the country is now bumping up. We've been very good, but we are not declining still. So we're not like all the red states that are coloring going up massively. We have not seen any uptick at our place, but we probably won't for the next few weeks with all the protests and everything that transpired around the country. It takes a couple weeks before you see the ramifications of that.
Sol, same question.
At Duke, our protocol has been no one has surgery unless they're tested within a 3-day window, 72-hour window. So we have now ramped back up to about 85%. We had about 8,500 patients in the queue waiting for the door to crack open. And when it did, we had a surge of elective cases, but now we've sort of settled back down to about 85% of our capacity. Our routine is to test everybody. Nobody will have surgery unless they're tested. And if they're tested positive, they go down a different algorithm where obviously protective precautions are instituted. If they're tested negative, then we treat them just responsibly, but without having extraordinary patient protective gear as a necessity. To segue that question, though, to the perioperative prehabilitation point of reference, I think what we've learned is while we were in that holding pattern and waiting to sort of reopen our ORs, and it may be that we go back as we see now a second surge of the first wave to having delayed, if you will, the acceptance of elective patients. There's a silver lining there. It gives us an opportunity to really proactively evaluate the patient's modifiable conditions, to bring it back to the discussion we just had. If these people are in the queue and they're waiting for surgery and we're only bringing them in at a slow trickle, then shame on us for not proactively looking at their comorbid medical chronic conditions and getting them more fit. We should be much more aggressive now that we have the time and the luxury to manage their poor glucose control or get them in a smoking cessation program and on and on. So we've taken advantage of this delay by being even more aggressive in managing our preemptive strike, if you will, against their chronic comorbid medical conditions.
Thank you very much. I say we'll deal with the NHS view on that tomorrow in a protracted session tomorrow. So if you hold the COVID-19, Dave, for now, if you could.
Monty,
yes,
Monty, I'm just going to pick up on 2 points because you can't stop me. So Sol's point, absolutely, and we need to change that terminology from waiting lists to preparation lists. We need to get our patients actually prepared for surgery, and this is the perfect opportunity to do that. And we need to have that paradigm shift, that mindset change. And then the final bit that we didn't perhaps tease out of that is this is the perfect opportunity to really have those open and honest discussions with our patients, and this is the chance to actually truly embed shared decision making.
Fantastic. So I'm going to stay with you now, Dave, to ask you, where do you see the role of medics, i.e. geriatricians, in preoperative medicine? Could they play a role in optimizing patients prior to surgery?
Well, absolutely, and they do. So if you look at some of the work that's come out of the guys in St Thomas's group and the POPs programs, all of that's already happening, and there's some established and quite mature programs to develop comprehensive geriatric assessment in terms of the perioperative clinic. So I think there's a role for anyone in perioperative care who's interested in perioperative care, be that surgeons, be that anaesthetists, be that physicians, geriatric physicians, or whoever. And of course, it's not just medics, it's the blended workforce, the roles for our AHPs and our nursing staff.
So, Kay, speaking to that, I get the impression that actually, although there's shared leadership, a lot of the work is done by non-physicians and indeed increasingly non-nurses.
Absolutely. We have a group of physiologists, dietitians, physiotherapists and nurses that work with us to develop the pathways for our patients. And I think it's richer for the multidisciplinary team working together to actually try with the patient, putting the patient at the centre. So that's shared decision making that was referred to earlier. It's about everyone working together to get the best outcome for that patient, and that outcome may not be surgery. We mustn't forget that.
I was just going to make a quick comment along that line. Yeah, I think it's all care providers, number one, and nursing, nurse practitioners, PAs. A lot of what is necessitated on the preoperative preparation side that can be universally applied. So whether it's your physiological reserve, physical activity, nutritional aspects, underlying stress reduction, those kinds of things, those should be preemptively managed by nursing and others. There are programs that work off of DVDs. We just have to know what are the key things that give us the biggest bang for the buck. But then there's personal accountability. And when we've done all this cost talking before, one of the differentiators in the U.S. versus anywhere else, 10 most developed countries, you can track our healthcare costs after 60, total healthcare costs, against all other countries, and it looks like a hockey stick. Then you can track our obesity levels in the U.S. against all other countries, and it looks like a hockey stick. A lot of our problems come from situations that relate to personal accountability that we're not going to change readily here.
Thanks, Jeff. The next question up on Slido, is there a formal structure or template you would recommend to bring forward a business case for starting it says a rehab program here, but I'll take all of the prehab and rehab programs. Sol, any way you can look for a formal structure for a business case? Then I'll go to Dave.
Yeah, we've done this, and we're pretty disciplined in doing this for every program that we launch with respect to addressing a comorbid medical condition. I think you do a pro forma and you look at, and you accept the fact that we still do live in a fee-for-service world, and there are codes that exist that recognize work and pay you for the work that is recognized. And so there is a contribution margin that is integrated into our business modeling. How many patients do we see? What is the likely percentage of those patients that would be affected by this disease? And we, do the usual sort of payer mix analysis and charge capture analysis. And that's the easy part, if you will, of the pro forma. The much less easy part of the pro forma that we do as well is the cost avoidance part. And to that, we apply the data when it exists, and our speculation as best we can when the data does not exist to look at what the cost savings would be in a capitated or risk-bearing, if you will, kind of population. Now that gets very, very convoluted and complex. What you would need to do is really understand what the penetration of risk-bearing contracts are for whatever population you have with the payer mix and the payer relationships that you have. Right now, I can tell you Duke University Health System is about 25% penetrated with risk-bearing contracts, quickly on its way to 50%. So if you apply a cost avoidance calculus to a risk-bearing percentage of the population, then it's a very different arithmetic in your pro forma than when you just simply apply a cost sort of basis on contribution margin based on the volume you make. Long story short, it's complex math when you develop a business model, but we do this rigorously for every program that we launch, and we do it responsibly. So it's not just change for the sake of change's sake, it's change to be responsible both to the health needs of the patient and the economic health of the institution.
And David, in the NHS, is there a sort of business case template you can grab and build on someone else's previous work? You'd think as a sort of single system, it would be 95% pre-written for us.
Yeah, so each individual trust will have their own business case process. For a system-wide business case, you'd be looking at the traditional 5-case model, but for individual trusts, it'd be a much simpler aspect. So in terms of the perioperative preparation, so your co-host will have a closer knowledge of the the Southampton experience, perhaps with the Westfit data that's going on. In terms of the rehabs, Manchester is currently doing quite a significant trial looking at cancer patients with some stratified prehabilitation and rehabilitation in that. And so certainly, if they'd like to contact me via CPOC, we can put them into contact to get that form.
So I've just jumped a question up here. Should we concentrate on the business case, financial costs and major complications, when most patients often focus on different outcomes to the medics? So do you think there's a tension between what patients see as good outcomes and what managers see as good outcomes? Absolutely.
And I think within the NHS, we've been very much directed by the government in terms of the NHS 10-year plan to put the patient front and centre. And it's what they want and what their outcomes they want to get that is important. But I do have a caveat for that, because I think we also have to, through shared decision making and giving them a lot of good quality information, allow them to help to have the information to make that decision. And I think this relates to some of what Sol's been referring to, where we need to make sure we've got really robust collection of data around all of our outcomes, and making sure that we use big data to look at how everything performs, so that we can then use that information to help our patients with their decision making. But again, the patient needs to be at front and centre for that.
Dave, on that one?
So a couple of points. Building on that, I think we focus in the UK a lot on organisational outcomes or individual physician outcomes, and I think what we should be really concentrating is clearly patient outcomes, because after all, that's what we're doing this for. It's what's important to them. And I think there's still lots of work to do on that. In terms of the capturing some of this, so we have the PQIP program, which has been running for a number of years now, the Perioperative Quality Improvement Program. Over 100 trusts are already involved in this, capturing the data. It's the world's largest quality improvement program for perioperative care, and by that we will get the big data that will hopefully give us the answers.
We've had PROMs, patient-reported outcome measures, for I don't know what it is now, it feels like over a decade, and they haven't had enormous penetration outside of their initial data sets. Why do you think that is? They're there for joint replacements, for example. They're there for, I think, varicose veins and hernia repairs, but they haven't been universally adopted.
My understanding was originally when they came out, they were going to be rolled out across all types of surgery, but really stopped with that. Interesting, if you talk to the orthopaedic fraternity, they're very wedded to the PROMS data. I think, again, the problem with this is it's the physicians saying, this is what we think the important outcomes are, and we'll capture those with you, and you tell us what you've got, as opposed to seriously asking the patients, well, what's it important to you?
Jeff, I thought the weighting with regards to patient satisfaction was changing quite substantially in the USA.
Well, they're trying to make it more, and I've heard a case set, et cetera. Again, just to throw a little different slant on it, if we depend on patients to drive what is right when they're not paying for it, we're making a big mistake. David said we have to be outcomes driven. I totally agree, but which outcomes matter? We've shown in orthopedics marked reductions in length of stay for total joints. Find a patient who says, I want to go home day one versus overnight. And you'll find a lot who'd rather stay in the hospital for various reasons. I'm not saying which is best. So we push length of stay on the basis it does reduce cost. And in theory, takes you out of an environment that's not good, but we haven't shown a reduction in post-op infections or anything by a day change in outcome. So we have to figure out what outcomes are the most important, which impact complications that cost money or result in negative events to patients. But we have to drive that bus, in my mind. Any study that looks at singular things often is missing something. We have lots of data looking at singular things, but then when you go deep and dig into the weeds of the study, whether it's propensity matched, underpowered, it doesn't hold up against true tests.
I'll jump on the bandwagon, but add to it rather than divert from it. I think we have to be careful to not dismiss the patient's responsibility from the outcome of health that we choose to measure. And I think we're backing into that passively. It's a business-related question, so the answer is it's about the money. And so long as we put a burden of economic responsibility on the patient, then we're going to be more likely to motivate change in behavior. We're seeing this a little bit right now in the States with higher deductible insurance programs being predicated on the patient's choice. But we're also seeing these external tensions, very heavy external tensions on the provider or the service provider to divert the care to the least costly place of service. So, everybody knows that going to a hospital is a very expensive encounter, and it's much cheaper to go to an ambulatory surgery center, et cetera, et cetera. But the likelihood of a good outcome if somebody is high risk at a place that isn't geared up to take care of high-risk patients can also backfire. So we're upstream in the position to bend that risk curve by getting patients who would heretofore be perceived as too risky to do in a low-risk environment to then be better suited candidates for low-risk and less costly environments. And I think that's also part of the burden of responsibility of perioperative medicine and what we do in that total cost of care continuum.
Last question I think we can handle, and this one's particularly written from the perspective of when writing business cases, a split between commissioners using NHS language, i.e. what we call CCGs compared to NHS England. But let's look at it as the challenge of payer splits. If you've got within the system, we understand the patient side of it, but sometimes the financial beneficiaries or where the cost burden lies is in different pockets of money. So in the NHS compared to when they have a long-term problem out in the community. Are we at a point now in our system where we can look at it as a single payer system within the NHS? Or do we still have those splits?
From that language, that sounds very much as though it's relating to NHS England. And so I think we are in the perfect opportunity to have those conversations with the development of the STPs and the ICSs, because that should give us the whole pathway of care. The integrated care systems or this sustainability and transformation programs, which are the new language in delivering localized health care. And what that does is that set us up, rather than individual organisations, more towards partnerships and care partnerships, similar to some of the familiar American models like Centene. And if we can all work together and the various commissioning agents can be sold the vision of perioperative care, then they will get that and they will see the impact that it has both on the front end in terms of the referral, and the comment was made about actually surgery is not necessarily the answer for every single patient. And through the provision of surgery and the secondary care right through the recovery and rehabilitation and getting back to work. So I think there is that opportunity now with the change of the system with NHS England. But again, in the Four Nations, so CPOC is a Four Nations initiative, and so within the Welsh system and the Scottish system, there are good examples utilising their slightly different systems.
So very briefly, do you have any payer split challenges in your system, or in North Carolina, Blue Cross Blue Shield, for example? Do they cover all of the healthcare bills that, I'm not saying they pay the total of the bill that comes in, but is there one payer to deal with? Or do you have different?
No, we look at these data every day. I certainly look at it carefully with my team every week. There are many payors. There's government, and within government there's Medicare and Medicaid, and now Medicare Advantage is a very rapidly growing, if you will, segment of the payer mix. And then, of course, we all have individual contracts with individual third-party payers that are predicated on risks and discounts and rates and all kinds of innovative, if you will, contracting for innovative payment structure. So it's very complex, and it's a science that we track carefully because it all adds up, at the end of the day to either being enough for us to pay our heating bill or not. And so we manage accordingly.
So I'm sorry, we're out of time, I've just been told. So I'd love to take some comments on that from you, Jeff, and from you, Kay, but otherwise I need to ask you, thank you very, very much indeed for contributing to this session.
Top Med Talk.
Thanks for listening to Top Med Talk. We are excited to announce the World Congress of Perioperative Medicine happening in London this year. Check it out at ebpom.org. It will take you through to our carbon-free conference center where it has the EBPOM platform. You can find more information. Be sure to subscribe to Top Med Talk and EBPOM at ebpom.org.